Hey y'all, got a nice little video today explaining kind of acids, bases, and how they're used in EMS. Okay, so in this video, just kind of going over a little bit of a brief as to kind of the basics of respiratory and metabolic acidosis and alkalosis, what you would expect to see with your patients out there in the field, whether they be in the house or the ambulance or even sometimes in a hospital setting. So let's kind of go ahead and get started to sort of break it down as nice and easy as I can to begin with. What's going to drive kind of everything is where the pH is sitting at in the body. So your body in its nice, natural, homeostatic state loves and wants to be around anywhere from 7.35 to 7.45. That is where the body's natural pH kind of wants to hang out. So with that, essentially what happens is some form of a mixture causes either a drop or a rise in that. If you were to have a drop in the pH, and for some reason you go into an acidotic state. If you have a rise, you go into a alkalytic or alkaline state. So kind of basing everything off of where your pH stands will tell you kind of where you're lying, whether, like I said, you're in a respiratory acidosis, metabolic acidosis, or a respiratory alkalosis, metabolic alkalosis. Hopefully, obviously, you never ride within that, and they stay within the 7.35 to 7.45, and everything is good. But if that were the case, you wouldn't be watching this video. So, as you breathe, you exhale carbon dioxide, or CO2. And you also exhale a little bit of water within that, just because that CO2 is kind of getting mixed with the blood as it's coming out, and your blood is made a lot of with water. For any chemists out there, obviously whenever you have two elements that are kind of coming together, you have a reaction. So what the reaction of this causes is something known as H2CO3, or carbonic acid. Carbonic acid does not like to kind of be together, so what it does is it kind of splits off. And what you have from that is you have HCO3 and a hydrogen ion. So you have HCO3, which is, if you've ever heard of bicarb or bicarbonate, that is essentially what that is. And then you have your remaining hydrogen from what would have your bicarb, your acid over here. So, kind of what you will see a lot of times is essentially, if you're dealing with a respiratory acidosis, respiratory alkalosis, there's going to be an issue within this side of the spectrum. If you're dealing with a respiratory alkalosis or a metabolic alkalosis, you're going to be dealing with an issue in this area of the spectrum, where, like I said, your pH for some reason is going down or it's going above where its natural form is. So with a respiratory acidosis, what you have is essentially you're not breathing enough carbon dioxide off. So you have an increase in carbon dioxide, which is going to cause an increase in the amount of water that it's kind of helping attach to and everything as you breathe it off, which then, as the products of everything kind of come together, you're going to end up with more hydrogen ions. More hydrogen ions brings your pH down, making it acidotic. So a lot of times what you will see with somebody, like I said, out in the field with this is for some reason they are not exhaling enough of that CO2 off. What can cause that is sometimes you can have an altered LOC. You can have somebody that is tachycardic. You can also have somebody that is diphoretic. With a respiratory acidosis, which you will see a lot of times in the field because they are not breathing off essentially that carbon dioxide, is you will see somebody that is having an altered LOC, that they are becoming tachycardic, they are becoming diaphoretic, and a lot of times they start to develop a headache as well too. Big things that kind of cause this, obviously, if you are just ventilating properly and stuff like that, or if they're just completely apneic, they'll obviously be in this because they're not able to breathe off that carbon dioxide. Your COPD patients are very prone to this. Your overdose patients where their respiratory drive is depressed. Your pneumonia patients, your smoke inhalation patients, your pneumothorax patients, and then anybody that has like an obstruction, obviously, that for some reason is impaling the ability to breathe off that what you're normally breathing off, your carbon dioxide, causing it to rise, causing, through the equation of this, an increase in your hydrogen ions, causing you to become acidotic. So what can you more or less do for these patients? You can try to help bag them. Essentially what we need to do is we need to increase the respiratory rate as well as the respiratory depth. Because if you sit there and you're just going with like a BVM or something, you're not doing them any favors. You need to essentially help them adequately ventilate and get rid of that CO2 to kind of bring the CO2 level back, to bring your carbon dioxide level back down to kind of equalize this equation to where you're no longer producing more hydrogen ions. With a respiratory alkalosis, what you're going to have is essentially why that's going on is they are breathing off way too much CO2. So you are depleting and breathing off way too much of this, which is causing essentially a very much decrease in this. So you're going to have a lot less hydrogen ions. And as I said before, if you have more hydrogen ions than what you should have, you're going to be acidotic. If you have just the right amount, you're going to be perfectly fine. If you have less than the amount, you're going to start to become alkalytic. So what you will see, essentially, this is a lot of your patients that are hyperventilating, whether that be from shock, whether that be from somebody that is in a DKA state, which kind of mixes in a little bit with a metabolic condition, because essentially what your body is doing there is you're breathing off a lot of you're breathing off as much CO2 as you can because your body is in a metabolic acidotic state, so it's trying to increase your respiratory rate to kind of even things out. So that's why they'll be breathing very fast through that. Somebody that's very anxious or has a history with anxiety, somebody that is in pain, you're CHF patients will often have this just because they're trying to catch their breath through everything, so they're breathing a lot faster. Your sepsis patients are very prone to this. Again, just trying to correct a little bit of a metabolic issue that's going on. So a lot of times what you will see with this is they start to get kind of that numbness feeling around like their lips, around their extremities, but more so like around their fingertips, around their toes. Um, they can sometimes have a seizure with this, and then eventually the bad part about this is you continue and continue and continue, and just eventually you're not going to be able to keep up with that, and you just lose your drive. So what are we going to do for our patients that are presenting like this? If they're awake and conscious, try to coach and calm them down. Um, you know, if you have somebody that's really, really anxious, try to coach and calm them down. One simple little tip that I've used that kind of helps me with this a little bit is I credit, as much as I hate to say it, I credit Night Watch for this. Um, but I'll tell somebody to, try to take a nice deep breath in through their nose, like they're trying to smell a really nice set of flowers, or try to smell their favorite aroma in a room, and then just slowly blow out like you're trying to blow out 100 birthday candles all at once. That will kind of sometimes help reel them back in and help kind of hopefully lower their respiratory rate. Um, if you're bagging somebody with this, and you start to see, a couple issues going on, slow your rate and essentially slow your rate of compressions, because you are going way too fast that they're not able to, with your assistance with bagging them, get rid of um, enough of CO2, so it's continuing to, like I said, you're essentially blowing off too much to where you're not able to maintain where your level should be. So as far as respiratory issues go, that is where you're going to have like your respiratory acidosis, respiratory alkalosis, kind of what you'll see in your patients in the field, and kind of what to do to help them out. So getting into metabolic stuff. So like I said, your respiratory issues are going to that way, dwell basically from your problems over here. Metabolic stuff is going to deal with. So with bicarb, it kind of acts, and a best way reference to deal with this is it's kind of like Tums for your bloodstream. Um, so the more or less Tums that you have in your bloodstream to help kind of soak up that acid, the more or less um, acidic or alkalitic your blood and everything is going to be. So with a metabolic acidosis, you essentially are accumulating too much acid in the blood, so you don't have enough Tums, so to speak, um, for that acid to kind of bind to the oxygen and everything. And so you have more acid, which creates a higher number of hydrogen ions, which again brings your pH down, similar to what I was just saying about the carbon dioxide issue. So a lot of times what you're going to see with your metabolic acidotic patients, you're going to see them, be tachycardic, have what's called pulmonary edema. Um, they can be very tachypnic because they're trying to balance everything out with that. Sometimes they will appear very kind of altered or disoriented. Um, and then if it progresses worse enough, they can end up in a coma. A lot of causes of this. Obviously, a cardiac arrest, just because you don't have the processes going on that are supposed to be going on that's normal within the body. Um, your DKA patients, like I kind of alluded to earlier, whatever I was talking about, the respiratory alkalosis issue, your patients that are having diarrhea for a really long time, so they're expelling a lot of um, fluids and everything like that. Um, if you've got somebody that has overdosed on aspirin or antifreeze, just because that's going to really mix and match with the pH of the blood and everything. So, kind of what to do if you start seeing your patients within that area. Try to increase the rate and depth of your ventilations. You could also consider giving them bicarbonate if you're on an advanced truck, or if your particular protocols allow you to give sodium bicarbonate to your patients. Just because, like I said, it's going to help kind of bind to that acid and just kind of help equalize where your pH and everything in your blood and whatnot is. It's very, very, especially with like your aspirin overdose patients. That's one of the first kind of things that they teach is to go ahead and give them um, bicarbonate, just to kind of as a first acting thing to kind of go in there and help bind to everything. The only time I would say to, be cautious about giving bicarb is in your diabetic ketoacidosis patients. Um, Getting into metabolic alkalosis. So your patients with this um, essentially have too much Tums, or so too much bicarbonate in their blood, not enough acid to kind of go through and soak it up. So a lot of times what you're going to see with this is, clinically wise, you're going to have patients that are exhibiting seizures. You're going to have patients that are having a headache. Cardiac dysrhythmias are very, very common with this. So, because essentially, like I said, what's going on is you've got too much of a base and not enough of an acid to kind of equalize it out. Um, Diuretics can sometimes cause this. Patients with cystic fibrosis are very also prone to it. Um, People that chew tobacco, oddly enough, for like a prolonged period of time, are very, very prone to this. Your individuals that are, you know, taking penicillin or in some way, fashion, or form have access to like an outside source of bicarb and they're taking that, whether it be like, I don't know, whether it be a supplement, or if somebody has just given them too much bicarbonate in a proposed treatment type setting, and kind of shift things into being like this. Um, Basically, the only thing that you can do and the outside part of it or en route to a hospital is just try to keep them alive as best as you can. So try to go back to just your ABCs and do your best to keep them alive, because essentially what has to happen is you have to give the body time to use up that excess bicarbonate. Um, it's unfortunately not anything that you can really give them to soak that up or help alleviate that. Like I said, just go back to your basic BLS, ABC type stuff, or do your best ALS measures to help keep them alive long enough for their body to kind of recoup from that. The only last thing that I will touch on is, it kind of goes a little bit away from like your respiratory, your metabolic type stuff, but your kidneys in your body. And I think this is very, very good to go over because we deal with a lot of patients that are on dialysis, um, or just have end stage renal failure and they're not on dialysis. Um, so your kidneys, being kind of the filter of things, have a fail safe kind of protuberance to them. What I mean by that is, so if your kidneys sense that your pH is too high, it's going to cause you to essentially pee more to try to balance out where that pH is sitting and everything. If it senses that it's too low, it's going to try to retain that and everything. The only issue is your kidneys aren't a very fast acting organ system in that manner. So it's not something that is going to, be a quick treatment option. It's going to be something more a little bit longer term for your kidneys to kind of go in and do that. But they are very useful for that. So where I kind of bring this up and why I think it's important, because we deal with dialysis patients a lot of times. Your dialysis patients are chronically acidotic because their kidneys are just obviously not functioning properly. They're not able to kind of help compensate for that, and so you're just going to continue to build up acid within the body. So if you have a dialysis patient and they start to go down, provide them adequate ventilation, maintain their airway. Again, if you are able to give sodium bicarbonate through your protocols, or I know paramedics throughout are able to give it. I just know sometimes an advanced EMT or EMTs in some areas can maybe give it. That's also going to be very, very beneficial for those individuals that start to crash and go down hard. Because, like I said, their kidneys, obviously, they're on dialysis, they're not functioning properly, so their kidneys are not able to do that. So, giving them that extra sodium bicarb to kind of give them that extra Tums in there to go in and bind and soak up that acid will hopefully see an improvement in their prognosis. Any questions over this? Please feel free to leave them down in the comments. I have no problem going a little bit more in depth. I try to not go too much in depth with this, just try to keep it somewhat minimalistic and somewhat useful for what we would see out in the field, whether it's being how your patient's presenting, what you can do to fix it, and just some things to kind of look out for. As always, I appreciate any feedback, any support, and everything like that. I very much appreciate you guys coming in and stopping in and watching this video for me. If you haven't already, please hit the like button, hit the subscribe button. Doing my very, very best to try to grow this as best as I can, to try to help out as many people as I can. And then, yeah, I think that's it for now. Again, thanks for stopping and watching this, and I will see you guys in the next one. Thanks.